Welcome to another episode of the NEI Podcast. I'm Dr. Sabrina Siegel, live at the NEI Congress 2022. In this extended Q&A episode, we take some time to sit down with one of our incredible speakers and allow the audience a chance to have their unanswered questions addressed from selected presentations. In this special episode, we're on site at the beautiful Broadmoor Resort in Colorado Springs.
Welcome, everyone, to this episode of the NEI Podcast. We are not only at the Broadmoor, Colorado Springs live, but we are in the bull ring of the exhibit hall. And we have an audience watching this recording right now. I have the privilege of interviewing Dr. Jeffrey Strawn on his incredible presentation earlier today titled Blue Genes, Using Pharmacogenetics to Guide Prescribing. Welcome, Dr. Strawn.
Thanks so much, Sabrina. It's great to be here live with you.
Absolutely. I'm so excited. In this episode, we have a chance to allow Dr. Strawn to answer some of your unanswered questions from earlier today. As you know, you have a chance to submit questions whenever our speakers present, but sometimes they run out of time and they don't have enough time to answer everything.
And that's certainly happened to us this morning.
Exactly. All right, so here we go. Our first question for you. I have used combinatorial genetic testing for years. What is your best literature source that I can send to an insurance company that is refusing to pay for testing in a patient with multiple drug failures?
That's a great question, and let's try to unpack that a little bit here. So when we think about genetic testing, remember we have the single gene, where we're looking at something like 2C19 or 2D6
right,
or SLC6A4, but we also have the combinatorial testing. And a number of different commercial entities have different platforms here. The combinatorial testing uses an algorithm in order to weight the importance of these different genes. So in my presentation this morning, I spoke about sertraline,
right,
which is metabolized by 2C19, but is also metabolized by 2B as in boy, 6. And so what an algorithm might do is actually weight the relative effect of 2B6 and 2C19. Now, in terms of the bulk of the literature supporting testing, it's really focusing on single gene.
Right.
So looking primarily at those pharmacokinetic genes. But in terms of this issue of does insurance cover it, I think there are a number of sources that we could use for this comment. And so one is certainly the CPIC guidelines.
Okay.
We could also reference in a letter, and I have an example letter that maybe we could even put on the website.
Excellent, yes.
That explains the rationale for using this type of testing, and specifically includes various details from FDA, as well as the Dutch Working Group, and some of the other evidence-based groups that are publishing guidelines here.
That's great, that's great. Thank you for sharing that with us. The next question is, what are your thoughts about the American Academy of Child and Adolescent Psychiatry discouraging the use of pharmacogenetic testing in child and adolescent psychiatry?
So this is a complicated one. This is really the third rail. But let's go ahead and touch it.
Okay.
So about a year or so ago, the American Academy of Child and Adolescent Psychiatry published a guideline, and the guideline is somewhat vague. Although I certainly do read it as discouraging pharmacogenetic testing. Now, in response to that, we actually published an editorial. A group of pharmacogenetics researchers, child and adolescent psychiatrists, clinical pharmacists, and others published this editorial that really looks at what pharmacogenetic testing does and what it doesn't do. And the other thing that I think is important in that editorial is we emphasized what the FDA says. So here's a situation where if we recommend against testing, yet the FDA says you should use this testing to not use this particular dose of a medication, we're really stuck.
Yeah. Okay, the next question I have for you is, can you comment on the practice of only prescribing medications with no drug-gene interaction, the medications in the green column of the report? What can you share with us?
Yeah, so I think the person asking this question is referring to a specific commercial testing that may bin the medications in terms of likelihood of having a gene-drug interaction. So the issue is when we use medications that only have no gene-drug interactions, it potentially eliminates medications that have a substantial evidence base. And we see that this is particularly the case in child and adolescent psychiatry, although it's really the case in treating adults and geriatric patients as well.
Right.
So in many situations, what you might notice is that desvenlafaxine is almost always going to be in that no gene-drug interaction column. Why is that? Well, the reason that that is the case is because desvenlafaxine is a metabolite.
Right.
So it's been through 2D6. So 2D6 is not going to affect its concentrations.
Right.
The issue is that we know for desvenlafaxine, just as an example, that it has little to no efficacy in generalized anxiety disorder or many of the other anxiety disorders, and may in some patients not work as well as an SSRI in treating depression or certainly in treating anxiety. And so the issue is if we base our decision only on whether the medication has gene-drug interactions, we potentially take something that could be helpful to the patient off the table or out of the toolbox.
Right, right. So there's other factors at play here,
Absolutely.
and we have to make sure we pay attention to that.
Right.
Okay, the next question is, do you have any thoughts on multimodal antidepressants like vortioxetine and the serotonin alleles? Do we treat them similar to SSRIs or differently?
Yeah, so I think maybe if we can take a step back and maybe if I can try to be inside the person asking the question's mind, I think what they're really getting at is this idea of the serotonin transporter promoter polymorphism, that SLC6A4. And so what we often see is that in some of these testing reports, if folks have something other than a long form, were shunted over, or rather away from the SSRIs. And so, again, this is one of those situations where it could move us towards a non-evidence-based intervention.
Right. Okay, the next question is...
Actually, Sabrina, I don't think I totally answered it, now that I'm thinking about it.
Go ahead.
So in terms of the question about vortioxetine or some of these medications that have more multimodal effects, I don't think that we really have the evidence based on the pharmacogenetic testing and specifically that serotonin transporter promoter polymorphism to say don't use an SSRI or use a multimodal agent. I think that's really where we need to go back to our clinical decision making.
Right, yeah. Okay. The next question is, I have performed genetic testing on one sibling. Is it necessary to do it for all of the siblings, or would it be the same?
It probably will not be the same unless they're identical twins.
Yeah.
And as the father of twin daughters, that's an important consideration.
I'm a twin too.
Excellent. So we're well represented in terms of twins.
Yeah,
up here.
exactly.
So I think one of the questions here is that when we're looking at, say, a parent's family history or a brother or sibling's family history, I could have the mom of the patient and know her genotype, but I only potentially know 50 or 25% of the child's genotype, right? Depending. And then it becomes even more complicated when I consider if there are other genes, other than just one gene, that are affecting the medication response here. So I guess the answer is no.
Yes. That's what I think we were looking for. Okay, the next question is, when is the ideal time for a pharmacogenetic test? At the start of treatment or after multiple failures? That's a great question.
It's a really good question, and this is something that we really struggle with. And unfortunately, I'm going to give you a depends. So again, going back to that first step in the algorithm, what you would do for the patient, if this is a patient in whom you're going to start escitalopram, then it may make sense to actually get the pharmacogenetic testing early on. If this is a patient in whom you're going to start desvenlafaxine for some reason, it may not make sense to get pharmacogenetic testing at all. It's not going to change what you do, and it's not going to change the dosing.
Okay. Can you speak to the impact on the MTHFR gene mutation and its impact on different neurotransmitter systems?
This is a tough question, but this is a common one. And so really what this is getting at is this relationship between MTHFR, methyl tetrahydrofolate reductase, and whether we would supplement with something like L-methylfolate. And we'll talk a little bit about the adult data, and then we'll also talk about the pediatric data. So in the pediatric data, it's pretty easy. No, the study is negative. In the adult data, or in terms of the adult data, it's a little bit more nuanced. So in terms of folks with reduced conversion, some will actually supplement. In folks with normal conversion, many will actually not supplement.
Okay.
I have colleagues that are on both sides of the fence here in terms of what they would recommend. I generally think in terms of the larger American Journal of Psychiatry paper, just generally showing the universal effect of L-methylfolate supplementation.
Okay.
So in this situation, I actually don't use the MTHFR genotype to guide what I might do.
Okay. Great answer. Okay, the next question is, given short CERT expression, should we avoid SSRIs or implement a medication with an alternative mechanism like vilazodone or mirtazapine? What are your thoughts on that?
That's an easy one. No, no, and no. So what that serotonin transporter is telling us, or that polymorphism, is that we may have a different trajectory of response. In my opinion as a clinician and as a researcher, I think one of the worst things that we might do is actually use that testing in order to use a medication that has not been studied in that disorder or for which there's negative evidence in that condition. So we know that with the short allele, we will have a reduced response to the SSRI. But I want to be careful here. That's not to say that we will have a better response with an SNRI. As we talked about this morning, what that probably relates to at this point is that there's some evidence for differential dosing here. So we're not, in those short patients, not going to get that additive benefit of really pushing the dose. Why? Because we've already blocked that serotonin transporter at a lower dose of the medication.
Right. Is there a software program to help that accounts for all medications, not just psychiatric meds?
There is. You guys want to know what it is? All right. It's called Sequence to Script. And I really like it and wish that I would have included it in my presentation.
Question.
And I'm not sure why I didn't. But Sequence to Script is a program that's actually from a university. You can go to it. I like it for a couple of reasons. One is it's easy to use. Two is it's free. But one of the things that's really nice about it is that it gets at this idea of pharmacogenetic testing as a clinical decision support tool. So what you do is you go to Sequence to Script, you type in the patient's alleles. I think there's actually a drop-down menu so that you enter if the patient's a 2D6 poor metabolizer, and then you list the concomitant medications that they're on. And there's a nice little click box. And then it will tell you, or rather give you the guidance from various evidence-based entities in terms of how you might dose whatever other medicine you're considering. So if, for example, you were considering escitalopram, it will actually tell you no dose adjustment necessary based on the information that you've provided.
That's wonderful.
And it's free.
Yeah.
So we can maybe even put the link to that.
Absolutely. We'll put that in the show notes. Yes, for sure. Okay. Would you ever consider dosing escitalopram or sertraline twice a day for an ultra-rapid metabolizer? Is there a risk of withdrawal effects early in treatment for ultra-rapid metabolizers?
Yeah, so that's a really good, somewhat complicated question. And this is where really when we look at the current evidence that we have, it unfortunately just comes from modeling studies and of course our clinical experience. So in our modeling studies with sertraline, there may be some benefit of the BID dosing. And certainly we've seen clinically that there are some patients in whom that dosing seems to be a little bit better.
Right.
Now withdrawal, particularly with SSRIs, is just something that's really difficult to measure and assess. And we all know this as clinicians.
Right.
So again, does that mitigate potential withdrawal symptoms? Well, ostensibly it could.
Right.
But I don't think we have really the prospective evidence to suggest that. But certainly our models would suggest that it produces a more normal exposure, so that blood level over time. In some of those ultra-rapid metabolizers. Interestingly, we haven't looked at that, or rather haven't found that effect for escitalopram.
Interesting. The next question is, do the effects of the serotonin transporter gene polymorphisms vary across different ethnicities?
They absolutely do. And this is really important. Because when we look at folks from African ancestry, what we find is regulation of that serotonin transporter is actually very different. And so again, this is a huge issue when we think about the diversity of populations that are really represented in our testing and in our research. And quite frankly, as a field, we have to do a lot better.
Yeah, absolutely.
So we are doing some things to try to move this forward. And actually at the recent Pharmacogenetic Research Network meeting, there was a larger initiative to try to help with this. But the person asking that question is pretty savvy.
Yeah, that's great. But that's great news. What about the deletion for the DRD2 gene? Can you comment on this?
Yeah, so this is a gene that's really been looked at primarily in ADHD. And unfortunately, the studies have been pretty mixed.
Okay.
And so this is one of those situations where I think we really do need to take a step back and be cautious in applying this to certainly the choice of stimulant or alternative pharmacotherapy for ADHD that we might consider.
Right, okay. And that takes me to our last question, which is, do hormones and or menopause affect CYP metabolism?
Yeah, so they almost certainly do. And it's important to consider both inhibitory effects, and it's also important to consider substrate competition. So the other thing that's important is when we're thinking about menopause, unless it's particularly early menopause, we need to think about when that's actually happening. And one of the things that we know is, especially for CYP2C19, we really start to see a decrease in activity beginning around age 60. And so I think that's something that's really important when we're considering escitalopram and sertraline, but probably even more important when we're considering citalopram, particularly given the risk of cardiotoxicity, or at least maybe that's not the right word, maybe QTc prolongation in those older patients. And I think that's probably one of the things that subtends that guidance from the FDA about the dosing of citalopram in older patients.
Yeah, it's so fascinating. Well, thank you so much for sharing all this incredible information with us.
It's been a pleasure to be here, and these are great questions.
And thank all of you for submitting these excellent questions. So make sure to subscribe to our podcast. You can go to neiglobal.com/podcast.
Thanks so much.
Thank you.
Thank you so much for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.